morning, everybody. My week starts on Tuesday, so I've got a bit of Monday-itis. Just one user coming in. Can you just check that your microphones are on mute? I try to put that setting in. And just while user still coming in, beautiful. I'll just let you guys know that it's already being recorded. So if you want to turn your cameras off, we're not going to be offended. I'll just start off with a quick intro of myself. So my name is Tyler West-Chong. I'm here in Meanjin, Brisbane. However, I'm from Mount Isa, Kalkadoon country. Other than that, I'm just going to let people in as I go, but I'll pass it over to Sue Kildea. Thank you.
Thanks, Tyler, and hello, everybody. It's great to see you. We usually sort of give a few minutes for people to come on. We know that more than 60 people have registered for this, but we also know that they can't always come on at this time and they often watch it later. So I think we'll get started because we don't want to waste people's time. I'm talking to you today from the lands of the Yuin Nation, based in Nowra, and with working very closely this week with the Waminda organisation, who I'm sure many of you would know. So my name's Sue Kildea. I'm a midwife who's got a mad passion for midwifery research, and have been working on the Birthing on Country work and trying to improve services for Aboriginal and Torres Strait Islander women for many years of my career. And I'm really excited today. I'm going to talk to you about two awesome midwives who are going to actually tell you the story of a really ambitious and successful project that they undertook down in Naarm in Melbourne. So it's we've got Res McCalm and we've got Della Foster, who's one of the professors of midwifery down there, and they're from La Trobe organisation, La Trobe University, and Della's a joint appointment with the Royal Women's as well as the professor of midwifery. And we were just talking a little bit before everyone came on and before we opened up, and I was scratching my head and saying, when did you get this grant? Like, how long ago was it? Because it feels to me like it was a long time ago. And indeed it was. So what they're going to present today and talk about today is really probably a culmination of about 10 years' work. We were saying, like all NHMRC grants that people sort of apply for, you hardly ever get it the first time you do it, and often you're successful the second time, which I think was the case with these guys. And just so that everybody is aware of a potential conflict, I'm not talking it up and saying this is a brilliant project just because I was involved at the very beginning, which I was, and I want people to know that. I'm talking it up because it really is an awesome project and has had wide-ranging impact. So I'm not going to keep talking for the moment. What I'd like to do is let both Res and Della present. They've got a presentation that could go from sort of anywhere from 40 to 50 minutes maybe. And if you've got any questions, please put them in the chat. I'll try and keep track of them. We won't interrupt their presentation, but I'll try and moderate afterwards. And then we can have a bit of a chat if there's time, if people have got queries and questions about anything to do with the presentation. So welcome, everyone. It's just great to see you. Before I kick off, I'd like to acknowledge the traditional lands that I'm on today and that everybody else is on today, and pay my respects to elders past, present and emerging, and pay my respects also to any First Nations. It looks like it's mostly women, but it might not always be today. But First Nations peoples who are on this presentation today. So I haven't done a big introduction. Della and Res, if you'd like to introduce yourselves just a little bit more and get started, that would be tremendous. If everyone can stay muted, as Tyler asked, that would be great as well. So thanks very much. Over to you guys.
Thank you, Sue. We're going to sort of do this presentation jointly. So I'm going to talk a bit, then Res is going to come on, then I'll come back. Yeah, as Sue said, we don't really know how long it'll take. I said half an hour and Res was shocked. such a short time. So I'm a midwife by background, like Sue said, and I've been working sort of always in a hospital and a university for a really long time now, because I've always really wanted to stay within sort of both sectors, not just become some sort of academic. And I still do a little bit of clinical work whenever I can, so mostly antenatal clinic. And in terms of my research, it really has been across all sorts of anything to do with pregnancy, birth, having a baby, postnatal period. But I suppose especially models of care, how care is provided in pregnancy, which this project is about, and has built on some of our other previous work. And I also do a fair bit of work in workforce, midwifery workforce, trying to have enough midwives and keeping them in the profession, as well as a bit of perinatal mental health and breastfeeding. I'd like to also acknowledge the lands that I'm doing this from today, the lands of the Ngunnawal people, up here for something else tonight, but also the people, the Wurundjeri lands of the people from the Kulin Nations where the research was conducted. Rez, do you want to just say a bit about yourself before we then change over to the talk? See if I can work the slides.
Della. Thanks. Hi, everyone. I'm coming to you from Wurundjeri country. I'm Rez. I'm a midwife. I've been working on this project since 2017. I'll talk more about my part of it later. I'm a Noongar woman on my mum's side, but I was born and raised off country here in Naarm, and I've been a midwife for maybe 8 years, I think. But I won't take up too much of the time. We'll just get started. But thanks so much. We're both really excited to present today.
Yeah, thank you. Great. Now, let's see if I can share my screen. Okay. Okay. Can you all see that? Does it look okay? Excellent. Okie dokie. So the project we're talking about today is called Baggarrook Yurrongi, and that is women's journey in Woiwurrung language, which is the language of the Wurundjeri people of the Kulin Nations. And we're talking really about like Sue said, about the whole project, and it's been quite a journey, implementing a midwifery continuity model of care for women having a First Nations baby in 3 Victorian maternity services, and it really is an overview of all our outcomes. First thing, the slide won't move on, but I'm sure it will eventually. Yeah. So first of all, I'd like to really sort of talk about all our sort of various people. Not everyone's included here, of course, but this is it takes a very big team to sort of do a whole lot of work like this. And so this is just some of the people who we've worked with over the years, and who mostly have been with us from the beginning. I've put sort of yellow highlight on the First Nations people, which is heaps of people here, as well as others who are not here. And particularly like to acknowledge Auntie Di Kerr, who was with us from the beginning and helped name the project, and Auntie Desina Fergie as well, and the various health services you can see on there. Okie doke. So I think you sort of mostly know about this sort of stuff, but the reason we started this work was that evidence-based strategies are needed to really redress the higher burden of poor outcomes for people having a First Nations baby in this country. So higher rates of infant death, low birth weight, preterm birth, maternal mortality, for example. And I'm going to talk about some of our figures at the start of the project in a little while. We'd previously done quite a bit of work on models of care and how care is provided in pregnancy just generally, and we know that continuity of midwifery care is associated with improved outcomes, both for clinical things as well as increased satisfaction with care and much more positive birth experiences for women who have their own midwife. And we did a large study like that ourselves in Sukhill Day here did a whole lot of work up, and team did a whole lot of work up in Queensland as well, same sort of thing, and found really decreased odds of having a preterm birth for mothers who had a continuity of midwife care having a First Nations baby. But in Australia, if you look at who can access these midwifery-led continuity models, it's really limited. And somewhere between 10 and 15% across the country at all have access to this model, where you have an own midwife who looks after you all through pregnancy and comes in on call for labour and birth. And on top of that, women having a First Nations baby are even less likely to get this sort of special gold standard model than non-Indigenous women. So we did a large study called the Cosmos Randomised Controlled Trial, where we looked at having your own midwife, and did that have an effect on outcomes? And we found things like way less caesarean section, much less sick babies, less babies admitted to special care. Women's experiences were drastically improved, and midwives really liked working in the model. So we were presenting this work back in 2014 or so, 2013 or 14 or 15, around then. And a team from the Victorian Aboriginal Controlled Organisation, VATCHO, were hearing our work, and they said to us, we would really like this model for our mob. And really the work started there. And I think in 2015, we applied for a grant to try and get this sort of work underway. Didn't get it the first year, and then we applied for a partnership grant and got it the second time, which was fantastic, only twice. Sometimes you've got to go 5 times. So that's where it started from. So just to sort of talk a little bit about Victoria, and I got some of these from Res yesterday, this nice map, for example. Just in terms of across the whole country, 37% of First Nations women birthing in Australia actually birth in major cities, and that's from the Australian Health and Welfare report. They mostly birth in major cities, and then only 7.2% of First Nation births were in Victoria in 2020, and just over half of those were in Melbourne. So in terms of like the country, we don't have a large proportion of First Nations births in Victoria, and just over half are actually in the largest city. But if you look at Victoria, the First Nations birth rate has actually been increasing. So it was 0.6% of births in 2000, and it was 1.6% in 2021. And down the bottom here on my slide, you can see that, so that's that 1.6% of women having a baby in Victoria in 2020, in 2021 were Aboriginal, and there's 1,271 babies. But if we looked at First Nations babies, that was 2.2% of all babies. So almost 2,000 were reported as being Aboriginal. So I think the numbers have really risen in Victoria as well. That's sort of just about where we are. So in terms of our journey, which it's hard to see past just things at the top of the screen. So Baggarrook, our overall aim was to assess the research translation capacity of our partner organisations, which I'll talk about in a moment, to actually implement a model, continuity of midwifery care, and embed it in their systems and sustain it. So this one-on-one caseload midwifery model, specifically for First Nations women and for non-Indigenous women having a First Nations baby. So that was our big aim, because we knew what the evidence said. We'd been talking to VATCHO and talking to lots of people. So our aim was that. We also we looked at, could these services actually implement the model once it had been developed? What did women think about it? What were their experiences? What were the clinical outcomes? Did they change? And could the model be sustained if it did make a difference in the organisations? Now and then this thing doesn't advance, but it will. I'll just try all my tricks to sort of see. Now, here we are. Okay. So we're going to talk a snapshot really across all our outcomes today. So we'll talk a little bit about how the models were set up. And I know they're quite different than sort of the models that you looked at in Brisbane, Sue, for example. I'm going to talk to you about the primary outcome, which was implementation, women's views and experiences, the midwives' views and experiences, very short for the midwives ones, clinical outcomes, and some of the breastfeeding outcomes. We're still looking at the economic evaluation, and we've got a PhD student about to probably go back and look at all our data on the impact on child removal, because that's been something that everyone's really wanted us to be looking at as well, but we haven't done that yet, but we can. And the person on this photo is Kelsey Youngblood. She was the person who's on we had a story with the ABC at one point. She was our sort of person who had the Baggarrook model. This is her and her little baby Amelia. We went out to her house, so she matches all our colours nicely, and she's up here in Canberra with us as well, actually. So before we got started, we looked at all the data. So we had 4 hospitals involved: the Royal Women's Hospital, Mercy and Joan Kerner Hospital, all big tertiary hospitals in Melbourne, and Goulburn Valley and Shepparton Health. So what we wanted to do was to look at their data from before we started, before we put the grant in, and see what the differences were. And that was, of course, about how we argued to try and get the grant and the money. So you don't have to look at the whole thing. But if we just looked at the women's, for example, and looked down at the yellow bits here, you could see that the outcomes were really different. So birth weight less than 2.5 kilos, 8.1% for non-First Nations births versus 15. Preterm birth, so birth before they got to 37 weeks, 9.4 versus 15. Smoking much higher in the First Nations population, special care and nursery admission, breastfeeding much lower. But importantly, across the bottom, all of the 4 services, we chose them specifically because they were very keen to be part of this work, but also because they also already had a functioning caseload midwifery model, because we didn't want it to sort of get confused about can the hospital or health service set up sort of that continuity model in the first place. So we specifically chose those people. But if you look across the red numbers, the numbers of First Nations women who had had the model over the sort of those years, at least 3 years beforehand, were much, much, much lower, and much percentage-wise much lower as well than other women. So basically they weren't having access to this gold standard continuity model. So what happened was that despite lots of work with the Regional Health Service, Goulburn Valley, they could never get the model up and running at all. Mostly, we've had lots of interviews and stuff with them, but mostly they went through all sorts of really acute staff shortages. They had a few CEOs through a few directors of midwifery. Things really changed during that period of time. but despite our many road trips up the road. So who did come on board was the Royal Women's Hospital. So that's in central Melbourne, and that's called Baggarrook Caseload. And that started in March 2017. So probably a year after we got that grant. Joan Kerner Hospital, also called Sunshine sometimes, and they started Galangera Caseload, and they started in October 2017. We didn't sort of plan to sort of gradually bring them on. They just started when they were ready. And then Mercy Hospital for Women called Nanak Caseload, and that started in 2018, so almost a year later. So just to sort of clarify then what the model actually was in this project. So it was sort of pretty much based on a standard sort of caseload midwifery model. So women received midwifery continuity of care. So they had a midwife, they were sort of allocated each other, the one and the midwife. They had their pregnancy, labour, birth and early postnatal care from their primary midwife with 1 or 2 backup midwives in the group. So mostly groups of 3, which I'll show you in a minute. They had 24-hour access to their midwife or backup, including being on call to attend for labour and birth. But importantly, and this is different from standard caseload models, the care was provided in conjunction with the existing supports for the First Nations women. So the Victorian Koori Maternity Service, which is at a number of sites across Victoria, and the local Aboriginal Health Services. So, for example, at the Women's Hospital, the Victorian Aboriginal Health Service, or VARS, was our main sort of close health service. And the aim always from the beginning and continues to be not to replace any existing supports or any of the people in the hospitals, but to really enhance them. So it's sort of a model with lots of add-ons, and definitely lots of collaboration with the hospital-based First Nations health workers, as well as the standard people like obstetricians and health professionals, etc. And with in Victoria, often with caseload midwifery models, the model's just the women either choose caseload midwifery and they have their midwife, and it's pretty hospital-based, or they might have a satellite clinic. But here, the women could choose. They could keep having shared care with VARS or their health service. They could mix up the model, whichever way they want to have it, but they could still have their named primary midwife. And a lot of people, not the majority, but many did still have shared care with the VARS midwife, for example. So we really wanted to sort of streamline this thing between community and hospital health service. So it's really a hospital-based sort of starting point, but lots and lots of collaboration with the various health services, but particularly VARS in the case of the Mercy and the Women's. The sites weren't at all homogenous, so we've sort of, they had different amounts of supports around them. The caseload sizes were different. I'll show you a different slide with more of that information in a minute. The women attending the 3 services had different sort of background characteristics, if you like. Some of they had different numbers of women or percentages of women who were higher medical or obstetric risk as well at different sites. This is one of our first early meetings at the Women's, actually. So so at the Women's, as I said, it was called Baggarrook Caseload, and it means women or women's journey, actually. Baggarrook Yurrongi does. So we started it March 2017. So at the Women's, there was lots of cultural awareness training throughout the project, and VATCHO provided that largely. And we had regular and ongoing tailored education for all staff, including ward clerks. And we really looked at, focused on all the things that sort of stop women being identified. We looked at internal referral pathways, identification processes, and lots and lots and lots of work on data integrity. That was the same across all sites. And I think one of the big things when introducing models like this is just like really looking at the internal systems, because that's where we don't find the women. We don't know, we've got no idea where we're even missing data. So our project midwives were really critical in doing all this sort of stuff, because we never would have had the engagement without sort of ongoing focus people. There was lots of engagement between the caseload midwives, our Aboriginal liaison officer, Auntie Gina, who's here in Canberra as well with us, because we're going to a sort of big dinner tonight, and from VARS. At the Women's, it was an all-risk model. Well, they all were in theory, but 51% of the women going through our model when we were collecting data were actually medically high risk as well. We started with 3 midwives, which was 2.8 EFT, and by 2020 that had increased to 3.8 EFT, but it's now even a tiny bit higher, and now 4 of the midwives at the Women's are First Nations. 4 of the 5 midwives that we've now got are First Nations. During the period of the project, the increase in bookings for women having a First Nations babies was 69%, so women heard about the model and they really wanted to come. At the start, the midwives it was very hard for them. They were looking after 40 women every year per 1 EFT, but that's now 35, and there's discussions that it might go lower or be a bit more acuity-based. There's no leave relief for the midwife, so it really wasn't sort of that you just could take the number of midwives you had, that's how many that we could take per year. We had at the time at the start 1 ARLO, and that's increased now to 2, now 3 at the service. So you can see things have really changed at the women's during that period of time. We had one of our project midwives, her mum was busy knitting these little hats. So every baby who was born in the program got a hat, Aboriginal or Torres Strait Islander, depending. Okay, so then Gallangira at Joan Kerner, they started in October 2017. Again, VATCHO did a lot of the cultural awareness training and had lots of regular engagement, and they had a much larger Aboriginal health team on site than the women's did. They did a lot of work at being able to capture the Aboriginal status of the baby, and they developed a whole new registration form for babies as a result of the project. So we found at all 3 services, having the project actually meant there was action happening in the service about identification and care for First Nations babies and mums and families. So at Joan Kerner, they're sort of in the western suburbs of Melbourne. They had 53% of their women who are medically high risk, as well as the low medical risk. They started again with 3 midwives, which was 3 full EFT. They increased to 4 in 2020. I think they've still got about that many, but they've got 1 First Nations midwife as well, so that's good. So we've got now 5 First Nations midwives across the 3 sites who are providing this ongoing model. They had a 10% increase in bookings over the project duration, and they started with 35 women per year per EFT, and I think that's what they're at the moment. Fiona's on the screen, who's our project coordinator, and she'll be able to correct any of these things later in the question time if I've got it wrong. They always had more people. They had 2 Aboriginal health liaison officers at the start, a Koori maternity service worker, a social worker, and 2 obstetricians attached to the model. With the Koori Maternity Service in Victoria, that's run by VATCHO, and it's government funded. There's only 14 sites across the state, and only 3 of them are in hospitals. So this was our only hospital service that had a KMS worker as well. And Gallangira is Wemba Wemba language, and it means to come together and connect with love. And the ARLO at the time, her mum named that. And then there's the Mercy Hospital for Women. So they commenced NANAC in April 2018. They did a lot of their own, I think, cultural awareness training, and some with VATCHO, lots of education and referral pathways and stuff really similar, but lots of regular engagement again between the health service and VARS. And that was another really important outcome of this project. It was really that we've really it's not perfect at all, but it really changed the pathways of communication between the hospitals, the health services, and the Victorian Aboriginal Health Service. They had an all-risk model as well, but only 18% of the women who were in our data collection period were actually medically high risk, so a really different population. They had 3 midwives to start. That increased to 4 as well. They had a 38% increase in bookings over the project duration, and they're not that far from the women, so the women were coming. Basically, they started off with 40 women per year per EFT, but they had leave relief, so it's sort of effectively less than that. And again, even bigger sort of wraparound service with their ARLOs, their postnatal workers, social worker, and an antenatal clinic coordinator. And NANAC Aban Mara is Woiwurrung, meaning nurturing mother's spirit. So this is our lovely birthing tree logo that Shawana Andrews did for us. I think pretty sure Rez refers to it again later and actually builds on it really nicely. Our primary outcome was what is the capacity of our partner services to implement, embed and sustain a caseload model, especially for women having a First Nations baby. All the pictures are people in the model or at the 3 services. So this is our primary outcome slide. It's actually published in a paper already as well, and you don't have to sort of read everything. So this was from implementation, from wherever they started, you know, from different for the different sites, till the end of 2020. So during the project period here in this slide, we identified 1,040 women, and it was hard work doing that, but people really were on the ground and doing it. And some women were identified too late, so we found out at birth, you know, because you're asked at each different stage, do you identify? So, at Joan Kerner, they look after the women who are in prison, and 19 women, they decided that those women couldn't access the model, so they weren't offered it either. So 87% of the women who were eligible were offered the model, and 90% of those who said, would you like the model, said yes, please. And the main reason women didn't decline were really because they maybe were moving back somewhere else for birth, or they actually really liked their own shared care or local provider. I don't think anyone said, I don't want to have continuity. So over the whole period of the time that we were collecting that data, 660 women had the culturally specific caseload midwifery, and another 40 had standard caseload, so 700 all in all. My thing doesn't. Here we are. So it's the same, this is the same data been in a graph form, but it really shows it dramatically. So, you know, beforehand we had 34 women, like that first slide earlier on that I showed you, had ever had access to the model of these services. But over the same period of time, basically, we went up to 700, which is actually incredible, or 660 if you want to go sort of for the culturally tailored caseload. And it was published in the Lancet Clinical Medicine in 2022. Seeing I'm such a fast talker, it's a good thing my slides don't advance. So it's sort of like the gods. Every time I'm doing this, I'm just sort of pressing a few things and hoping. Here we are. Okay. So then we looked at clinical outcomes. That was, so implementation was our primary thing. Let's get this in. We know this is the evidence. So, but we also want to look at clinical outcomes. So we want to see if offering a culturally specific caseload midwifery to women having a First Nations babies could improve key clinical outcomes for mums and bubs, compared with baseline rates beforehand and compared with non-Indigenous mothers and babies. So looking at sort of that gap as well. The primary clinical outcome measure that we sort of said, how many babies do we need, was the proportion of First Nations babies born low birth weight or less than 2.5 kilos, because that's such an important indicator of your health and well-being and survival in the first 1 year and 5 years in particular. You have to talk among yourselves while my slides advance. Look at our lovely women.
And those beanies, they're just awesome.
Oh, no. Pam, what's her name? Matthews. I'm just going to sit for a second and see if it'll advance. I don't know why. Oh, here we are. Okay. Okay. And we looked at a whole lot of other clinical outcomes as well, of course. So the proportion of babies born small for gestational age, so less than the 10th centile, born preterm, less than 37 weeks, admitted to special care, commencing breastfeeding. And we looked at all those and smoking and antenatal visits and all the other normal things you would expect to sort of collect in a project like this. I see that I need to press enter before I even finish talking. I have got someone else, Fiona, sitting here. We are. So I've got someone else sitting up with the open in case we need to do that. We had to, this is for those who are interested in statistics, we conservatively assumed that 200 women per year, we thought we'd have about 200 per year at the sites, combined sites for our sample size calculations, and allowing time for the model to be implemented and embedded when we didn't want to collect outcome data. We thought we probably need around 650 First Nations mothers and babies before and after to find a strong association between does this model make a difference or not. And so we also collected all the non-Indigenous births over the same period, so we could look at the closing the gap thing. You're not going to get all that in detail because that'd be another whole talk. But we looked at, so it's a before and after design. We, of course, didn't want to do a randomised controlled trial. It wasn't appropriate. The community certainly did not want it. So we 650 babies. I think I said that already. Yeah. That's Cherie Stewart on the down the bottom one while we're waiting for the slide to go. So that she was the KMS worker and midwife at Sunshine or Joan Gerner Hospital when we first started. There's no beanies out there. They were at the women's. Don't you hate PowerPoint and slides shows?
I think it's actually okay because, as you identified, Della, you are quite a fast talker, and it gives us time to sort of just think about what you've said and formulate questions. And I think it's fine. It's
reassuring for me.
It is what it is. Information technology. You would have thought COVID would have made us completely schmick with all this, but it hasn't.
It never seems to work somehow. Okay. All right. So this is when I'm looking at the clinical outcomes. So this was sort of the beforehand data we had. We had from 2012 onwards for all those services. It's really complex data. They have data collected all in different ways, type of birth even is in different fields, and there was different electronic medical records. Then from whenever it started at each service, we had sort of a 6-month washout. So we didn't collect, we have got the data for those women, but they're not included in their analysis because we want to sort of, things were just settling in. And at the women's, we collected data to the end of 2022 because we could, until the others, it was to the end of 2020. And they, as I said, they just started really when they sort of wanted to, when they were ready to start. So when you're thinking about data like this, and Sue and I were talking about this before you all came on, what's the right comparison? So we could look at the baseline data of the First Nations mothers and babies and compare them with the non-Indigenous mums and babies, looking at the gap. And we could do the same with the after the after data, and compare sort of, this was the gap, say, with preterm birth here, X percentage, versus this is the gap here. So we, of course, could do that. We could just look at the First Nations mothers and babies before and after model implementation. We could also just look at it afterwards versus those who did have their culturally sensitive caseload or not. And then we have to think about whether we'd include all sites. But what we have done is actually look at it every way, which I'm not going to at all show you today because it's like pretty complex. We're going to go through a lot. This, you can keep reading my lovely words there about the right comparison. Be interesting what everyone thinks. And we have done them by site. I'm just going to keep talking while the slides are thinking. We have actually looked by site, but we're never going to present site data sort of, you know, in our papers or anything. But we've been back to all the sites, of course, and shown them their own site data and given them that, because we want sites now to be able to lobby governments and say, okay, we want this model funded. So it's okay for these guys, they've already got it implemented, but if they want to expand, because at all the sites, women are already missing out because everyone wants that.
Yeah, the advocacy with government sort of afterwards to really get full translation of your evidence into practice is a really underestimated part of research, and so important.
I know. So we're really trying to use. Yeah, we're really trying to use that. So I've said that. So the sites really had different support structures. The caseload numbers were different, and you know that thing about the sites varied by site. So with, say, for example, the number of high-risk women, 18% versus 53%. So the change is going to be different. And Joan Kerner, the Sunshine Place, became level 6 during 2019. So before, all their before data didn't have the really sick babies in because they would have been transferred out during pregnancy. So it's actually pretty complex. You see, I see you're good with your extra commentary while we're waiting for each thing. I'm sort of busy pressing my, oh, here we are. Good. So here's a little look at who they were. So beforehand, we've got data from those 3 services for First Nations babies. If we just look at beforehand, 1,104 and versus 101,000 non-Indigenous, and about 1,041 afterwards versus 63,000. So we've got a lot of before and after data. Beforehand, when we're looking at the data of the babies who are at First Nations, in the history, according to the history, 14% of the mothers didn't identify. So there was 14% of mothers who had a First Nations baby, and they were not. Afterwards, 29% of the mothers didn't identify but had a First Nations baby. That suggests we're doing a lot better identifying baby's First Nation status and the father of the baby's First Nation status. And certainly some of the sites did not ask that routinely at the start. The women's themselves asked it very poorly. Fiona, there's a whole paper on that we've published as well. So that's, for us, that's been a really important part of this, is this actually getting it right for the identification of the babies. But some of our funding in Victoria, I don't know what happens in other states, but I'm telling you this while I'm waiting for the slide to go. Some of our funding comes to the hospitals. You get extra loading for having for First Nation status, but the baby status doesn't count in that funding. So although we get a 30% loading, it's only for if the mother is First Nation. So that's one of the things we're really lobbying on, and we can really, people like the Women's Hospital are really sort of lobbying on that front. We'll get to 50 minutes this way, Red.
Is that the right way around? 14% before and 29% after?
Yeah, so some of the First Nations babies weren't probably captured properly in before data, because we only had 40% of the sample where their mothers were non-Indigenous, non-First Nations. That is the right way around, but it's hard to get your head around. We've changed how we've worded this a lot.
Yeah, so the number of mothers that didn't identify increased.
Correct. Yeah, by a lot, like it doubled, didn't it? 14 to 20, 14 to 30 virtually. God, if anyone could do my slides onwards, oh, here we are. Good. So this is the mothers and babies, just who they were beforehand. This is sort of the only slide like this I'm going to show you, because I'm not showing you that much data like in this way, but we can look at beforehand. This is non-First Nations, First Nations. You can see the age where the women were a bit lower, but in the after data, the same sort of difference. Marital status, much less likely to be partnered. They also were partnered. Slightly more likely to be partnered in the after data First Nations mums. Parity, much more likely to be primary for us in the non-First Nations. Smoking was higher, and we just looked at one of the things like BMI here, more likely to have a high BMI in the First Nations group, and sort of similar in the after data. They were sort of similar groups of women, I guess, is the main point of this slide. And when you're looking at big sets of data like this, and as I showed you, there was a lot of women in here. So I'm not presenting any more actual data as such today for the clinical outcomes, because we're still really rechecking everything before we get submitted for publication. We really want to have it right, and I don't want to be telling anyone sort of wrong things. I've given the site stuff there back. But, and as I said, the outcomes did vary by site. Well, I think the most improvement at the women's versus the other two hospitals. But so here, I'm just going to show you some data, the sort of really main outcomes. This will stay the same when we put it in our paper in a few weeks probably. This is the comparison of the women having a First Nations baby before model implementation with those women whose mother, with the babies, the First Nations babies afterwards, who definitely had the model afterwards. So we had 1,104 First Nations babies before model implementation and 556 afterwards. And if you remember, I said we needed 650 actually in those sample size calculations. But there was, no matter which way we looked at the data, and you know, I showed you all those various ways we could look at the data, no matter which way we looked at the data, there were significant improvements across all key variables. Whether we looked at the gap, whether we looked at this before and after, with just First Nations women who had caseload afterwards or whatever. But for this comparison, so all of First Nations babies before versus First Nations babies afterwards whose mother had the culturally sensitive caseload, the babies were 42% more likely to be born healthy. So that means being born at term, alive, not low birth weight, and not admitted to special care. They were 34% less likely to be low birth weight. That's a huge drop. They were 40% less likely to be born early. Almost no interventions that anyone tries across the world decreases preterm birth, for example, and low birth weight. This is massive reductions for those who are statistically minded. So this is where there's a strong association. The confidence intervals are not crossing 1. 25% less likely to be admitted to special care or NICU, and twice as likely to start breastfeeding. So those outcomes are very much in keeping with what you guys have published up in Brisbane, but quite extraordinary outcomes.
It's wonderful to see, really, isn't it? Because we published it in Brisbane, and that's one site, and you're thinking this is so exciting. There's nothing like it in the world. And to see that you can replicate those kind of findings across 3 sites it's so powerful.
It's incredible, isn't it?
It's incredible. Like,
so the
fabulous. Well done.
Thank you. The critics will say, well, this is the strengths and limitations. They'll say, well, it was before and after design. The women before and after might differ. You know, the women in the after period who got caseload might be different, but we've looked at it every which way. It's a really carefully collected data set. I forgot to acknowledge Taran Shaffi, who did all the data for us and put it all together. And we've really cleaned it. We've gone back to every single baby where there's any doubt about the identification. Fiona, who's on the screen, has looked at many hundreds of, you know, extra double checks, triple checks. So it's really carefully collected. We've taken into account any factors that we think might affect outcomes like age, BMI, partner status, parity, things we know, any diabetes type, any high blood pressure. And for these analyses, we've taken out babies who have got congenital anomalies, so and twins and triplets, but we couldn't have them in if we want. So no matter which way, the outcomes are better. Started pressing now. Yeah, so the gap analysis has closed the gap a little bit. Putting all the babies in, regardless of if their mother had caseload afterwards, also still was strong, not as strong association, but it's definitely there. So it still has an effect at a bigger group level. Had the least outcome, at least effect at the Mercy, and that's because they had the least high risk women.
Yeah, it's interesting when you actually get these big data sets, because you can actually look at who these things, these services seem to be working for the most, can't you? And
let's stop this and try and turn this on. Yeah.
Okay.
Yeah, exactly. I'm just going to see if I can just try and
So certainly we found, you know, the results do, depending on what cohort or subgroup that you actually look at, it changes, but it doesn't. Our results were very robust as well. Woohoo! Look at this.
Okay, Rez. I'm going to hand over
Publications.
to Rez, who's had a whole lot of work on women's views and expectations and published, and nearly going to have a PhD done in a minute. We got to say that, didn't we?
Thanks, Della. I'll whiz through this as quick as I can, just in the interest of time. But yes, I'm going to talk about the focus of my PhD, which was to explore the views and experiences of the women, and I'll discuss some of the key research outcomes. So just a bit of background. So it's recommended and recognised in policy that First Nations women should really be involved in the implementation of First Nations specific birthing programs, and their voices and views should be included in the design, delivery and evaluation of such programs. There is some existing evidence suggesting that First Nations women do value continuity of carer, and that these models can increase feelings of trust and safety, and that the likelihood of a negative experience in the maternity system is decreased when women do have access to a known care provider. But 3 recent scoping reviews do say that we do need more evidence on First Nations women's experiences of their maternity care. So that was a really important outcome of the Baggarrook project, was to see what the women thought. Thanks, Della. Yeah, it's okay.
Just letting you know, Della, you're on mute and we've lost the shared slide. But oh, there it comes.
Great. Okay. So in order to do this for this project, we decided to do an evaluation of care where we invited as many First Nations women that we could find at the 3 study sites to participate. And so in total, we actually found 343 Aboriginal women who agreed to say yes across the 3 sites, and they participated in an evaluation of care, and that involved completing a recruitment questionnaire during pregnancy and also postnatally, which I'll get to. And so in the cohort of women who participated, most of the women were Aboriginal and partnered. There was a bit of an even mix of primips and multi women, so women having a first baby or not having a first baby. And there was an even mix of women who'd completed any education after high school or not. We found approximately 1/3 of women were experiencing challenges with their mental health or dealing with the illness of a family member or recent death of a family member. And that really tells us that when planning for a baby, many women were experiencing significant life stresses. And although these figures can't fully represent the richness and resilience in community, this information did lead us to make a recommendation that these programs really do need to take a holistic approach in caring for First Nations women. And these programs need to be adequately resourced to be able to account for the context of women's lives. No, that's good, Della, if you just go back. Oh, no, yeah, that's right. So this study involves a very culturally diverse cohort of women. So ancestral ties to 76 different language groups were named. Most, but not all, women knew where they came from. And so that's also just a result of ongoing impacts of the stolen generations. And in Victoria, in this study, 14% of women knew how to speak their native tongue. So I think that this information is really important when we think about designing and implementing programs that encompass the principles of birthing on country models of care and maintaining that connection to country for women who are not birthing on their ancestral country or the country of their baby. Thanks, Della. So during this initial questionnaire, we asked women to tell us what they thought was important for their maternity care. And we found that women really value privacy, trust, unrestricted access to family, care that incorporates culture and access to their community, and easy access to services. So the findings from this first paper led to the recommendation that it's really paramount that maternity services partner with First Nations communities to implement culturally secure programs that respond to the needs of local communities. Thanks, Della. And then so this study aimed to explore levels of satisfaction among the women having a First Nations baby who received the care at the 3 sites. And we offered this opportunity to all women, regardless of what model of care they had. And so of the women who completed the recruitment questionnaire in pregnancy, they were then followed up by telephone at 3 to 6 months postpartum by a team of researchers, including myself as the lead researcher, Tanisha Springall. She's a Murray woman and midwife who did her master's on the breastfeeding outcomes. And we also had huge support from Jess B, a non-First Nations woman who was very, very respectful the way that she approached the task of calling women. And all women were offered the chance, the opportunity, choice, I should say, to speak to a First Nations researcher. So the follow-up questionnaire was completed by 213 women in the end. So that's about 65% of the original cohort were able to be followed up. And 87% of those had received this new continuity of midwife care model. Most women rated their pregnancy and birth care positively. Less women rated their inpatient postnatal care positively, but then it increased again once the women were at home. And so I'm just going to move my screen for a minute, sorry. And overall, the women felt informed that they had an active say in decisions and that their care was taken seriously, and that the midwives were kind and understanding. So based on this paper, the recommendation we made was that there were very high ratings of satisfaction with care. Most of the women received this new model of care, and so we recommend that programs be upscaled, implemented and sustained based on the women's positive feedback. Thanks, Della. So included in this postpartum follow-up telephone questionnaire were open-ended questions where women were able to comment in their own words about the care that they received. So this paper was just published in Women and Birth, and I'll talk to you a little bit about it now. We asked women to tell us what they liked about their pregnancy, birth and postnatal care. And the global theme for what women liked about their care was that they felt safe, connected and supported. And this included both emotional and clinical safety, having a known midwife, and also the women really liked it when they were able to be supported their way. I've got some examples of what many of the women were saying. So there are some quotes up here. I might just read them out. So one woman said, "I really loved the fact that 9 times out of 10, I was able to see the same one. I knew her on a personal level because when I had my son, it was completely different. And I really made the effort to tell them that I loved how they're doing things now." And this other woman sort of said, once I got to know them, it was just comfortable. That was the best part, feeling comfortable and safe in that relationship, because when you're getting care, you usually don't get to have that personal relationship, especially in pregnancy. And then so I might just go to the next slide because I know that we're running out of time, but really, really great feedback. But we also gave women the opportunity to critique their care. And so we asked women if there was anything about their care that they did not like. And so the women really did tell us what needed to be improved. So the global theme for what women did not like about their care was that it's a complex, fragmented and unsupportive system. And that included things like not being listened to, things not being explained, and a lack of cultural safety. So most of this feedback actually comes from interactions with care providers that were not their caseload midwife. So this is kind of the care that was happening parallel to or outside of their interactions with the midwives or the Aboriginal liaison officers. Some women commented, though, that their caseload midwife wasn't available as expected, or some of them were surprised if there were no Aboriginal midwives working in the model. But yeah, other than that, it was mostly what else was going on in the health service. Thanks, Della. So this is some examples of some of the things that women were talking about. So, seeing a different doctor every time, and then, sort of waiting 2 or 3 hours to see a doctor and then getting pushed back out again really quickly. Being stereotyped, experiences of racism in the wider service was still happening. So one woman talked about if her caseload midwife wasn't there, there was a very different attitude towards her from other staff. So that was really important. And, some women, when the continuity didn't happen how it was maybe the woman was expecting, women did comment on that as well. So I'll just summarize this paper. So we used thematic analysis to analyze qualitative data from this postnatal questionnaire, which was conducted via telephone. 213 women, of who 87% had the new model, participated. The global theme that what women liked was that they felt safe, connected and supported in the models. And the global theme for what women didn't like was that this system can still be complex, fragmented and unsupportive. And so basically the finding is that culturally tailored caseload midwifery models do appear to make maternity care feel safer for women having a First Nations baby. However, the wider organisation and system can remain challenging for some. So the recommendation we made from this paper was that these models should be implemented for First Nations women, and evidence-based frameworks such as the RISE framework should be used to facilitate wider organisation and systemic change. Thanks, Della.
Thank you, Rez. My thing seems to be working now, which is a relief. We've also done, Tanisha Springall did her master's on looking at the breastfeeding rates of the women that Rez has just been talking about. So those 213 women, that's published. And I'm going to show you that breastfeeding intention was only 77% planned to breastfeed and only less than half planned to breastfeed for 6 months or more. And I'm going to just say that 96% of women actually did start breastfeeding this cohort. That's the same as the population level, so way better than those first starting ones we did, those slides back at the beginning. 71% were still feeding any breast milk at 3 months, also above or at least equal to population levels, and 48% feeding only breast milk at three months, again, as good as population levels or better. So incredible breastfeeding outcomes, actually. I'm not going to talk about those bits. So then we looked at identification and documentation of First Nation status. I've talked a fair bit about midwives' views, and that's all published in papers. Fiona McClarty-Hoare has led these things. She's our project coordinator, so you can read up more, but just briefly, we did 29 key stakeholder interviews. We talked to Aboriginal staff, team members at maternity services, ACCHO staff, maternity managers, obstetricians, so lots and lots of sort of key stakeholder staff. We did 20 interviews with caseload midwives, when not long after that started, in 2 years, or if they resigned, and online surveys of caseload midwives. So we've got a lot of sort of collateral data, I guess, if you like, not damage. And so the midwives said overall that it was highly satisfying and rewarding work. There was no evidence of burnout when we looked collectively across the groups. Some midwives had struggled occasionally when they didn't have enough support, but overall, definitely not. A couple of comments. Well, I think the continuity is so priceless in terms of developing a relationship, and for women who are juggling so many priorities, not just their health and their pregnancy, you know, having a person they can call, having a person who knows their story and knows where they're coming from, knows what they're working with, I think it just makes such a difference. And we're very, very lucky in that we have three very different people, but we're really our midwives, and we really complement each other. We come together as a team and we support each other and trust each other. Our communication is incredible, but we also have our boundaries that works well. But model sustainability really needs to make sure we look after the midwives. Some key stakeholders said women are attending, and in Aboriginal health, that's your box of chocolates and your bunch of flowers, because if women don't like you, they won't come back and they'll vote with their feet. I've had women in the past trying to navigate the huge birthing factory, wouldn't even go past the reception, they've left, couldn't even get past. They felt people were judging them. They walked out. With this model of care, it's not happening. Women vote with their feet very much in this community. And another external person, it's been overwhelmingly positive. I haven't had a single negative comment. One woman said, I can't believe we can access through the public system. It was her first baby. She loved it. The crux is knowing your midwife. It's priceless, especially for women with complex histories. They don't want to go in and at every appointment and go over that again. So that was the key stakeholders as well as the midwives. So identification, we really did a lot on that. And I think I won't talk more about that because my slides have meant we're running out of time, my computer. So overall, though, this new culturally safe or culturally tailored caseload midwifery model was successfully implemented and is ongoing at 3 major maternity hospitals in Victoria. It's hard to get any model to keep going in those major hospitals, I can tell you. We went from 34 women to over 700 just in that 3-year period. Golden Valley couldn't get it up despite really trying. Very high model uptake. When we said to women, would you like this model? They said yes. The midwives, the women and key stakeholders were all really positive. Trust, respect, cultural safety or feeling safe and can support were key factors. And it's really hard to implement, to translate research. It's really rare. So this is amazing that these services and their Aboriginal sort of community stakeholders together did this. We're very proud of them all. And I know Annie Jean is on the line, I think, watching. So we think further scale up of the model should be really prioritised, and it really needs adequate support. The midwives have to be sort of flexible in the numbers of women they can take according to the acuity. We have to increase the number of caseload midwives so First Nations women are not missing out. We have to support the midwives. We have to really keep focusing on increasing the First Nations workforce. We do need allied, dedicated staff around the model. We can't just be reaching out to people who don't know the model, or the women or the midwives. The identification stuff is ongoing. We all have to work on that at every service we're in, and keep going with the cultural awareness and competency training. And just the lines of communication between the sort of the health services, the acute services and the community sector is critical, obviously, as well. We think that you have to really, obviously, a core aspect is the midwives, and they have to really want to work in the model. We shouldn't be allocating midwives to the model. It's not just a caseload model. It's a model that's really connected to the community. So that's really strong in our findings, and relationships really underpin the entire model. And it's not just about midwifery care, but this is the sort of known person in this health system in the organisation, but multiple people need to engage, and all models need to be developed and implemented collaboratively with the First Nations community. And our current personal sort of vision or aim is that every woman having a First Nations baby in Victoria has access to this model, actually. Just a quick reflection back. So this is the 2021 data in Victoria. And if we're looking at babies born before 37 weeks, this is sort of after our data collection period, after our model implementation. It decreased from 2020 and from the year before. So we think the women who had caseload in our group has really actually contributed to the Victorian data, because 1 in 5 women having a First Nations baby attend one of our 3 services that are included here. So we think we actually made an impact on the state data. So we really are trying to sort of work with policymakers to say we don't want to be applying for study grants to do this and help places implement it. We want you. We're happy to work with hospitals and whatever to help people come together, but we want funding and incentivising for health services to really increase the proportion of women who can access the model. So sorry about my terrible slides. That's why we've rushed through these last few slides. But we really want to thank everyone who's made this work possible. Our Aboriginal Advisory Committee for their input, especially Auntie Di Kerr and Auntie Jacinta Fergie, and definitely Auntie Gina, who's here on the line. Thank you to all the Aboriginal health teams at the sites and the amazing midwives who provided the care. And the managers really did a great job as well, getting the models up and running. Big thanks to Fiona and Taran, who did our data analysis, and to Shawana for our lovely project logo, the birthing tree. That's it.
Brilliant. Brilliant work. It really is. It's fantastic. I'm really sorry, everyone. We know that people have meetings that they have to go to, so we have to keep it to time. Any queries or questions, I know that Rez and Della would be really happy for emails and queries. If we get queries and questions, we'll forward them on. And I think that I can see that there's so much more that we could actually talk about. We might have to talk about another presentation at some stage or other, but massive congratulations to you guys and your whole team. It's awesome work, and so good to see that this is slowly starting to, we're translating research into practice across the country. We just need to really get it happening much faster. So thank you everyone for attending, and onward and upward. It's great news all round, so well done. What a team.
Thank you so much.